Morning, buddy. Morning. Thanks for coming. It was an exciting subject, so we had a lot more people than I anticipated, which is great. That's fantastic. It also probably means there's a lot of confusion and questions, right? I think we're all kind of thinking that right now is what's going on. I'm not going to get into politics so much, but you'll start to hear a little bit of how things are affecting us and what we're seeing and what we're trying to do as an organization. We've got about 18 people online, I think, in the group here too. This thing right here is an owl, so it's going to record different folks. It's going to move around based on who's talking. That's so the people online can hear us too. And really, the subject line of demystifying healthcare is something Jess came up with a really good topic. So Jessica Everlith is one that really put this together today, and Jim Macri really has helped with the IT side of it. So I just want to thank them very much for their help here. So it's a confusing time. We've been in the headlines as far as healthcare goes for many years. There's some confusion maybe about who we are as North Star Health. I want to have an opportunity to talk about that and what kind of services that we offer as well, and the type of folks that work here, our locations, the changes that we've made. But I also want to hear from you. So if you come with specific questions, if I don't know the answer to it, I'm going to tell you I don't know the answer to it, but maybe we can catch up later and I can find out. But if you have specific questions, I'm happy to jump into them if I do know the answers to those as well. So we'll kick it off. An exciting piece about what we've got with our slideshow today is really to enable to broadcast in foreign languages too. So this is really nice. We might have people within the community that English isn't their primary language, so we can actually translate this. This is going to show you how to do that. So if you're on Teams and you don't understand the English that I'm saying right now, you can choose your own language. That's one of the nice things about federally qualified health centers. And I'll get into what a FQHC is. So who are we? We're these people, but we're a whole bunch more. We're about 210 employees. We are members of your community. So we are doctors, we are administrators, we're nurses, we're facilities folks, we're answering the phones. We make up about the 210 people across several different locations. And one of the things that I did make some notes here just in case, that we really try to do is we really try to explain to folks how healthcare works as a 501c3. Does everybody know what 501c3 is? So not-for-profit organization. What we've been over the last several years is a loss operation, which has been difficult for our organization to really balance that piece out. I'll get a little bit into how we get reimbursed as an organization, and there might be some questions about that too. It's complicated, it's a very complex system. So as we're not-for-profit, we're certainly not for a loss organization. We have to make changes to be able to stay current and stay stable. Some of those changes you probably already read about, and you've probably heard from other FQHC leaders. If you've read the Vermont Digger articles, anybody kept up with those? And so some of my colleagues, I think I was quoted in a few of those as well, saying how uncertain times are for federally qualified health centers, but also for healthcare as a whole. So you've heard of Act 167 probably. Okay, so that's the hospital reports the state of Vermont did. They came to the library, did a presentation. Oliver Wyman was the group that did that. Did anybody catch that? Anybody be able to watch that? All right, so a few folks. It was interesting too, because they're really looking for a lot of community input on how to fix the healthcare issue as a whole. And I think that's because they're so multifaceted. And so let me give you a little bit of the history about healthcare in Springfield and kind of where the direction went. So I've been with the organization since 2006. I introduced myself. My name is Josh Dufresne. I think probably already people knew that when they signed up for this, but I'm the CEO here. I've been here since 2006. I started as the Director of Patient Financial Services. So I really got to learn how healthcare is not paid for. And it was an eye-opener to me. I didn't have a lot of understanding about healthcare. Everybody has been relatively healthy in my family, so we were blessed that way. But when I started to see how the economic side of healthcare worked, it was frightening. And that was back in 2006. And we were having conversations of how can we stabilize this system? There were, if longtime residents of Vermont or Springfield would know, Ridgewood Associates of Internal Medicine in North Springfield. You knew Barb Dalton, Yolanda Lawrence up on Wall Street. Those are just some examples of what we had as private practices in the organization or in the town or in the community. And those spots really got to a place where the reimbursement for private practice became so poor that the physicians that owned those practices approached the hospital and they said, we're not going to be able to do this anymore. We have sacrificed our own paychecks, given more money to our staff because we need to keep them. I can't keep doing this because I have to live and this business plan doesn't work. And so the hospital, what the hospital is really concerned of a lot of the times is making sure that they have the opportunity to serve the community with specialty services. That's going to be your orthopedics, your emergency room, your ENT services, urology, those kind of things. And so in order to have referrals from primary care and a place to refer to, there was a relationship that's needed to balance between primary care and hospital care. So people follow me so far on this? So what happened was the hospital then started to employ the private practices and brought that under the umbrella of the hospital. So you remember Springfield Hospital, and then we came out with this other term called Springfield Medical Care Systems. And it's like, what does that mean? And what is it? This is getting weird. They have two names now. Well, Springfield Medical Care Systems was the parent organization, and Springfield Medical Care Systems housed all of those practices that I just mentioned that came into the system. So when those practices entered the Springfield Hospital Company, if you will, guess what changed for reimbursement for those private practices? Anybody got any guesses? Try to get a little. Well, it's a good question. Not much changed. The reimbursement stayed relatively flat. And what happened was the hospital then had to subsidize those practices, whereas before the medical staff and the owners of those practices were subsidizing it with their own bank accounts. Okay. So what that did is that started to put a couple rocks in the pockets of the hospital, its pants, if you will. By the end of this, the pants fall down. I'll do a spoiler on that. So what happens is that dynamic of the referrals into the hospital, that works, that's important. We want to retain medical services for the community. The real inspiration of this is so patients don't have to travel very far for healthcare, so you can have it locally in your hometown, something we've grown accustomed to in Springfield for sure. And we're beyond Springfield, but this is just the focus on Springfield. So as that happened, what we saw is declining reimbursement over the years, increasing insurance premiums, and the hospital had a harder time breaking even as a whole. And so the hospital looked at different options, and there's this option called critical access hospital, and that's what Springfield Hospital is, critical access hospital. The average daily census, and that means how many people you have in your beds, was about 18 to 20. In a critical access hospital, anybody know why it's called a critical access hospital?
Can't have more than 26.
Can't have more than 25. So that's our cutoff, the critical access hospital. That's, yep, and 3-day stay. That's the max. You have to hold that as an average. This is Dr. Cody and Ruth Cody, very longtime employees of our organization. Thank you for your service. And so there's specific rules that we have to follow to be able to retain that critical access hospital piece. And I'm saying we, because this is back in time. And this is when the primary care and the hospital were together. And I'll get to how this shakes out in a minute. So as that moved forward, we saw reimbursement continue to shrink. And the critical access hospital designation was sought after and achieved. Critical access doesn't mean critical care. And that's something that some people get confused about. So critical access, it's critical that that hospital is in that location to serve the population, which is an underserved population. Meaning you're probably going to go without healthcare if that hospital's not there. So that's where that designation happens. It has to be in a medically underserved population. There's some other designations as well. So fast forward, the hospital and the leadership group then sought out another designation. That other designation was rural health clinics. And that's all of your outpatient primary care space. So that would be like this building. That would be like Barb's building up on Wall Street, or Ridgewood Associates up in North Springfield, Mountain Valley over in Londonderry, Vermont, Rockingham Health Center down in Bellows Falls that was there. So that Ludlow Health Center in Ludlow. So all of these sites then became rural health centers. So they operated as a designation called provider base. And provider base allowed departments of the hospital to then be in these outpatient sites. What did that do for our patient population? Well, that stabilized the way that we were able to achieve more reimbursement to cover the costs of the organization, but at the same time, some of those costs came out of our patients' pockets. Because when you're operating as an outpatient hospital, or as you're looking at the ways that the reimbursement happens on what's called a fee schedule, you will get charged more if you have something done in a hospital than if you would in an outpatient setting like this. Okay, and so that's where that designation helped that piece. We then transitioned shortly after that to what we are today, as a federally qualified health center, or FQHC. So I'll say FQHC multiple times. So it's a federally qualified health center. And that's a designation just beyond rural health center that I mentioned before. But we like to think of ourselves all as health centers. So I might also say health center. I'll try to stay away from acronyms. I have about 1 million in my head, and I'm sorry if I do say an acronym that you have no idea what it is, please raise your hand and say, what does that mean? And so as we became a federally qualified health center, that gives us grants from the federal government. And one of those grants, the biggest grant that we received, which is about $2.7 million, is the 330 grant from HHS, the Health and Human Services, or HRSA, which is the Health Services and Resources Administration. HRSA is what I'll say when that acronym comes around. That'll be the bulk of the acronyms for a little while. And so that gave us a bit more cash flow for the organization to stabilize at that time. We also saw Medicaid expansion come into the state, which helped us as well. When you look at a payer mix within a hospital standpoint, you have a different type of, when I say payer mix, that's going to be your insurance carriers. So there's going to be, the big ones are Medicare, Medicaid, commercial, and private pay. Those are the big four that we talk about. So everybody knows Medicare and Medicaid is really by the state, but it's funded by the feds, as we've seen in the news a little bit, and some concerns about that, as well as the state, who also kicks in funds for that. And then you have the commercial, which is your Blue Cross, your MVP, your Cigna, and those are really what a lot of employers have, and they offer to their employees. And then lastly, you have private pay. That's going to be your folks that do not have any insurance coverage whatsoever. And we're lucky because we do have Medicaid expansion in the state of Vermont. So we have the majority of our patients are covered by some form of insurance. But if you're covered by insurance, you just go in, you see your clinician, and you don't have to pay anything, right? Because you have insurance. Hey, not really. You pay your insurance money, but you still have to pay the doctor when you come see the doctor, right? So there's the co-pays, there's high deductible plans because you want your premium to be reduced. So you end up paying a higher premium for that. And then if you end up having to use us or a hospital, you end up hitting that deductible, and that comes at an unexpected time. So there's two things that we focus on healthcare when we really look at the way the business structure works. That's going to be bad debt, charity care. And so if somebody doesn't pay a copay or somebody doesn't pay a deductible, that goes to bad debt or charity care. We offer charity care at 200% of federal poverty guidelines. That's based on income, that's based on family size. So if you cannot afford healthcare within our federally qualified health center, we will do it based on the sliding fee, which can be up to 100% forgiven. Come in, get the care you need, you don't have to pay us a dime. So there's applications that you go through to do that. It's one of those things I feel like we don't talk about enough. Because right now, what I'm seeing in the country and what I'm seeing here in New England specifically is folks that are choosing to not receive healthcare right now. And they're putting it off. Anybody have any ideas why they're putting off healthcare right now? I know some of us in this room can't afford it. And why can't we afford healthcare? Well, it's expensive. But you know what else is expensive? Groceries, gasoline, heating oil, all of those pieces, housing, if you can find a house. So there's a lot of pieces that are really what we call those social economic barriers to overall living the life or that you need to live a healthy life. So you're going to make those choices. You're going to make those choices to heat your home before you make a choice to come in and get your sore throat taken care of, right? So if you put that off and you don't come in and you see us in primary care, you see somebody in our walk-in care, you will end up eventually, if you don't get better on your own, and I hope you do, but if you don't, you end up in the emergency room. Because you've exhausted that option of trying to recover on your own. You've eaten all the clementines that Shaw sells, and it's just not working. And you have to go to the emergency room at Springfield Hospital or some hospital, and that's going to be a much bigger bill than if you came for an outpatient primary care visit or a walk-in visit and received whatever you might need for meds.
Would there also be, maybe you have even some knowledge or statistics on that? Are there people who don't seek care, who might be eligible for some of these programs, but are unaware and are simply fearful that if I go in, a bill will appear and I'll be unable to pay it, when in fact that might not be the case?
Yes. Yes, that is the case. I see we have Sam in the room too for Valley Health Connections too. She's an expert in doing this. So really there's a couple things that I've found is people, one, so bad debt and charity care, right? So charity care is forgiven care by us or Springfield Hospital or somebody else that provides these services. And that's the patient filling out paperwork. And the paperwork is not impossible, but it's paperwork. And we all love filling out paperwork. So some people choose not to. And so if you choose not to and you don't pay, because it's easier for you to just not have to deal with it, that goes to bad debt. We send it to a collection agency. They won't collect it probably either. The collection agencies look at folks that do have collections that are due to healthcare on their credit report. And it's like, we kind of ignore healthcare as far as something that's on your credit report. So there's not necessarily the biggest incentive to try to work with us sometimes. We do work with partners like Valley Health Connection. We do have people that sit down with folks and help navigate that because it can be complicated. And they also help enroll in insurance, which is really important for us. So just to speed up the history a little bit, because Jess is probably like, we've got to get to the next slide, Josh. So the last time we had a town hall was 2019. Was anybody there? Happened to the Nolan Murray Center? Okay, so I won't go through all of that, but I'll tell you why we did that. Because Springfield Hospital and Springfield Medical Care Systems, now known as North Star, went through Chapter 11 bankruptcy. And so you probably heard that, right? And everybody's like, yeah. So I heard it, I lived it. I got a couple scars all over my body. You can't see them right now. But it was a really difficult process for our organization. Short story is heavily leveraged by debt, counting on reimbursements improving, counting on settlements to come from ACOs, which is an accountable care organization, counting on other things to take place as far as recruitment, as far as retention of providers. None of that came to fruition, and we weren't able to pay our bills. And we had a big lag in our bills, and we had local vendors that were owed money, and we couldn't pay that money. And the only way to save Springfield Hospital and save Springfield Medical Care Systems was to go through Chapter 11 and reorganize. And so that was a long process from 2019 to 2020. Once we emerged from bankruptcy, the theory and the thought, the desire was to have Springfield Hospital merge with another hospital network, and thinking that strength in numbers, right? And so there was that, those conversations were ongoing. Right now, for us to do that, because SMCS, or Springfield Medical Care Systems, was the parent organization. So the FQHC was the parent of Springfield Hospital. Springfield Hospital was a subsidiary. We had to spin the hospital outside of the business because there's federal statute that says a hospital cannot run an FQHC. Because some of the things we're reading about in the headlines about fraud, waste, and abuse, because we get specific grants, there's thought that a hospital would take those grants and use them inappropriately to subsidize other things. Our hospital wouldn't do that, but there might be some people in the country that would do that. So that's why that law exists. And so now we are independent. We're an independent FQHC. We're still a 501c3. We changed our name. Springfield Medical Care Systems, if you look us up on the IRS website or 990s, we're still there. We're still called Springfield Medical Care Systems. But we went through an enormous rebranding campaign. It was super straightforward. We just got it done like that. Nope. It took a long time. We went through logos, we went through names, we went through our values, we went through mission. What do we want to do? What do we want to be? So the biggest piece that we really wanted to do is take Springfield out of the name. And that's because we're more than Springfield. We cover more than Springfield, and that was important to us to not necessarily be centrally located in the Springfield environment. And so now we've been operating since 2020, December 31st, 2020, we've been operating as an independent federally qualified health center. Primary care if we go back to that understanding of how primary care is funded, it's funded at a loss, and it's funded at a loss countrywide. From an FQHC point, you're funded better because of those grants I spoke about. But the way primary care works is through contributions, and those contributions can come from patients. Those contributions come from insurance companies in the form of revenue for billings that we do when we collect those. And it also comes from different sorts of grants and different sorts of what I call other operating revenue. And so we'll get to that in a moment. So let's go to the next. So I've spoken about Springfield quite a bit, and I just think it's important that y'all know where we are. So Charlestown Health Center, that's our only New Hampshire site. That's our newest site. And that happens to be the only site that we built to be a health center. This building was not built to be a health center. Did you come upstairs today? Our elevator was broken for like months. And it was horrible. So we were carrying babies upstairs and strollers and everything else because pediatrics is upstairs. And then we were moving doctors downstairs to see patients when they were in wheelchairs. And it was really tough. So we finally got the elevator fixed. Hallelujah. That was because parts were unavailable. We apparently have a unicorn elevator that parts are unavailable for. Ludlow Health Center. Ludlow Health Center has gone through some rough times in the last few years. Floods. So Irene was a huge flood that took out Ludlow Health Center. We had that happen again a couple of years ago. Another flood, another thing, a new HVAC, a new system in the basement to really continue to operate that. Mountain Valley Health Center joined us in 2016. That was an independent practice, again, very much like what I shared with you before. They approached the system and said, we can't make it on our own. We'd like to work with you. And we brought them under the envelope of the FQHC. Springfield Health Center, that's where we are now. Fellows Gear Shaper, for those of you that have been local long enough. This was a HRSA funded building, so we had a substantial grant. Did anybody see people get on social media and they see the whole big buildings that are going to be built around us? Okay, so that's not us, but that's the owners of the building, and we lease about a third of this building. And there's been grants as well as hospital contributions over the years that have built this site out and made it possible to deliver healthcare, as well as clean up a lot of brownfields, which Bob left the room for a minute, but he's the expert there. North Star Vision. So that used to be Rich Lane. So Dr. Lane, if anybody knew about our vision site, which is up in North Springfield, which was right next to Springfield Auto Mart. So we rented that building, we gave that building up. They're right now downstairs. So all of our vision care is operated out of right below where I'm standing right now. And that used to be our billing center. And that's been somewhat outsourced, but also works with our electronic health record. So when you see your doctor there with the computer, that's our electronic health record. Chester Dental site. Chester Dental Center used to be a medical site too. We've converted that to completely dental practice. And that's been wonderful. We have 3 dentists full time there that are taking care of folks. So the dental portion of what we do something special as a federally qualified health center. We offer care to people that can't pay. We offer care to Medicaid patients. If you have Medicaid or you can't pay, good luck keeping your teeth. That's the reality of America. And that is one of the saddest things that I have to say. When you have, say you have an abscess in your tooth, you're not getting any surgery with an infection in your body. So that rules that out. You can have a lot of comorbidities that come from dental decay. So it's really important that we do take care of our teeth. And so we offer the sliding fee discount. Just as I mentioned in healthcare, we offer it in all the services that we do. But we also offer it to folks that can't pay. Good luck getting a job if you don't have your teeth sometimes. So really being able to come with us and so we can help you with that. And that helps with employment and brings people, lifts people up. Do you have a question?
You have to be in certain communities to be able to use that.
Yeah. So we do. So we should have probably put that on there too. So we have a service area that we serve. And so we can get you those zip codes. I can get you those afterwards if you'd like. Edgar May Health and Recreation Center, we have Christian Craig, Executive Director of Edgar May. So Edgar May, just down the road, swimming pool, weight rooms, saunas. We own that building. And that is a direction that I'd like to move healthcare in sometime eventually into what I would call well care or healthcare and not sick care, which I'll explain in a little bit. And that location is operated by Edgar May itself. We do not operate that site. We own the building. And so I just want people to understand that as well. School-based clinics, we're in 4 Springfield schools. For folks that can't get here, you'd be surprised at how many students really struggle to get to a health center for dental and medical care. And so we're able to do some services within the school system now, as well as behavioral health, which is really important because those students sometimes are trapped or on an island without those services. And then the Dr. Dolores Barbeau mobile unit, if you park down here, you saw it, it looks like a Winnebago. It's really cool. That allows us to go to different locations. If you have ideas of locations you'd like us to get to, let me know, because it's not out nearly enough. And I like getting it out there. And the hard part is when we put somebody out, we'll talk about home visits and things like that. I have to sacrifice a day of seeing 16 patients to see 3 patients if I take the mobile unit out. And that's not a financial thing for us. It doesn't work. So that could be done through donations. That could be done through other processes to do that, or volunteers. Anybody that wants to volunteer to help us drive it, that would be great. It drives like a boat, but it drives. We can move on, Chase. So I mentioned what we do, the primary care. I didn't really mention walk-in care. So I'll just, for a moment, primary care is so important, and it's so not thought of 99% of the time. Because when you're feeling good, everything's good, right? Maybe not. So there's specific diagnostic tests that we do to make sure that everything's good. Because our bodies don't always tell us when something's going on. And so that's why annual exams are so important. That's why wellness exams are so important. That's why what I would call preventative, proactive care is so important. Because what my goal and the goal of our federally qualified health center at North Star Health is to keep you out of the hospital, to keep you healthy, to keep you enjoying your average daily life. Now, does that mean that you're never going to go to the hospital? No, that's not what that means. You're going to need the hospital. And that's why the hospitals exist. But at the same time, I want to keep you out doing what you want to do, because nobody loves coming to the doctors. There might be a couple that I see sometimes that really love coming here, but for the most part, it's like, I got to go to my doctor's appointment or a dentist appointment. I'm going to get asked if I floss every day, and I don't want to have that conversation. Well, that's the reality of preventative primary care. And that's going to keep the overall cost of healthcare in the country down. Because if you're out of the emergency room and you're not getting expensive surgeries, if we can do things to really prevent you from having comorbid diagnoses, that will help you live a better life and save money. Because remember when I was talking about the insurance spends and the premiums and the out-of-pockets and the deductibles, you could have a great plan right now and you could still be paying out the wazoo for care, right? And that's just, it shouldn't happen. Not in this country. It shouldn't happen. It doesn't happen in other countries. So we got to figure that out. So come see us. We are available to be seen. I have access in our locations. We're continuing to recruit. We're continuing to have retirements of longstanding physicians that have been here and others, and that's hard for us. So we're in the process of balancing a lot of that as we're going through with primary care. Walk-in care is when you can't get into your primary care. Anybody ever had that experience? Yeah. So that's tough. If you call up, I want to get in right now, good luck. Sometimes that's impossible. Now, we might have something that's called a no-show that happens. And so we'll have somebody that's scheduled, so let's say for 10 o'clock in the morning. And everybody's ready. Chart's been prepped. We put some time into that. The nurse is ready, watching the waiting room. That person doesn't show up. All the things that we did in order to get ready for that visit is now not necessarily as valuable as it could have been if the patient was there. The other hard part is somebody else that was waiting to get in that day has no idea that we have a no-show right now. And it's really hard to get somebody to come in at that time unless they're waiting in the waiting room for an opening. And so that's one of the hardships about no-shows. We do charge people for no-shows, and it's $50. Now, if I get back to what I talk about a bad debt, charity care and those things, who thinks we collect on $50 all the time? Right? So if you've already gone to bad debt, where's your incentive to pay a $50 or where's your incentive to show up? At the same time, we cannot bill, it's illegal to bill Medicaid $50. So there's no real penalty if you no show there. Dental care, I really mentioned that, the vision care as well. So we do have an optical shop. This is my first set of glasses in my entire life. So now I'm a customer of that. And then behavioral health, which I think is so important. I'll touch on that for a moment. So we have licensed independent clinical social workers. We have nurse practitioners that provide psychiatric services and prescribe medications that are needed. We have psychiatrists that prescribe, we have psychologists that prescribe, or that do not prescribe, I'm sorry. And that therapy group is so helpful right now for the community and what we're going through. So we could probably pull out, well, we can't, but let's pretend, let's go to the La La Land. Let's pretend we open 10 charts and we see how many people have anxiety and depression. There's a lot. And so really being able to treat the folks of our community that suffer from those pieces to get to a better place is so important for us, because that's going to dictate a lot of this other stuff as far as how healthy you are. Okay, we can go on. So industry trends. So I just got back from Texas for a conference, and I can tell you, speaking from a nationwide perspective, it's not that much dissimilar from what we see in New England, but I can tell you New England's much worse off. And that's really around the lack of economic development, the lack of housing in New England, whereas other parts of this country are expanding. And so that's where you see a little bit of the changes. So things in healthcare, we're going much like I mentioned when we were talking about the 80s and the 90s, and we're employing physician networks and we're building that space out. The country was in a little bit better shape economically, obviously. Then this thing happened in 2019. Does anybody remember what happened in 2019, 2020? That was a real big hit for us. And unfortunately, we were going through bankruptcy at the same time. And so we had both sides of that COVID pandemic as well as the bankruptcy. So in the bankruptcy, when you hear somebody's going through bankruptcy, there's people that think, oh my gosh, I can't go there and get the care anymore because they're in bankruptcy. The reality of it is the organization operated like it always does. The bankruptcy, and there's several folks in the room that were part of helping us navigate through that, was really so that you didn't feel it. You read about it. There was a lot of scary headlines and things. And there was a lot of scary times that we were looking at how we were going to make it to the next day. But we really didn't want our patients, and we didn't want our employees to feel that. So we really tried to shield them from that while continuing to let them know where we stood. At the same time, the governor issued stay home, don't go anywhere. And where do sick people go? Well, I don't want to be around them. So I'm not going to the doctor's office, right? So we quickly moved to telemedicine. And so telemedicine was something we've been using in behavioral health for quite some time, but we're starting to migrate to primary care. How do you think a telemedicine dental visit goes? Not so great. So that was a place that didn't really work. But for behavioral health, it worked pretty well. And for primary care, it worked pretty well. But it's not ideal, because in an exam, there has to be a real good touch, a feel, an understanding, diagnostic test order, where you just do not get all of that when you end up having a telemedicine piece. So it does help, but it's not perfect. And guess what? Some insurance companies don't pay for it. And so that's another issue and if they do, they don't pay as much as an in-person. And so what we saw the patient access drop like a stone. So let's talk about the cycle of when you come in and you see us in primary care. You make an appointment, you show up. I know everybody in this room always shows up. You show up, you get seen, you feel pretty good, I hope, when you're leaving. And then you check out and you make your next appointment typically, right? So-and-so wants to see me in 3 months. Or, yep, I'll schedule my wellness exam or my physical exam for next year. Well, on telemedicine, you're not really doing that. And so you're not setting up that next visit. And so suddenly the impact has a ripple effect going through time, where the patient then says, oh, I have everything going on in life and it's stressful, there's a pandemic and I'm not going to get back there. And so we had to end up calling tons of people. We still do it today. We haven't seen you in a while. We got to get you in. And what's happening and what we're seeing in the hospitals is a higher acuity level going to the emergency room, because all of those pieces that were put off from that standpoint, from the pandemic and so on, have been brewing, and people are now going to the emergency room sicker. And eventually that's going to cause more costs for the overall healthcare organization. We did receive grant fundings from the federal government during that time, both the hospital and the FQHC did. We received funding from, really advocated from Senator Sanders, who's a huge proponent of FQHC, is a huge help to us. So we did receive what they call stabilization funds, one-time funds that got burned up really fast. But what we did is we kept all of our employees employed. And we were able, because when you try to recruit right now in healthcare, it's nearly impossible to find somebody. Especially if you're trying to find a physician, family medicine physician or an internal medicine physician, hard to find. Psychiatrists, I think the average age of psychiatrists in the country right now is in the 60s. And so these are some things that we need to think about within the future. So the rest of the country is starting to bounce back now. We're starting to see patients come back into the organizations, but not in New England. So we're still seeing a 2-3% loss on average from healthcare, hospitals, FQHCs, and so on and so forth. And so that's an ongoing issue. I was invited to a Scotney Hospital last week to have a conversation about healthcare stakeholders. State of Vermont, AHS, or the Agency of Human Services, all got together. How can we fix what's going on in the state of Vermont? We can't afford to increase premiums because the people can't afford it. Totally. We can't. And when you're increasing those premiums, I talked to you about where the money's going, right? It's not going to us. And that's the hard part because we're having the copays, the deductibles, and I'll get to the reimbursement side of it. So where's the money go? So it doesn't go to us, but we're giving you the care. And I can tell you, when I rewind back to when I was the director of patient financial services, I used to do this thing called follow-up. And so I'm going to pick on Shaw's for a minute because I like to pick on Shaw's. Everybody that's employed knows I like to pick on Shaw's. So when I was the director of patient financial services, if I used to use this example all the time. So if I went in, I'm going to keep it really simple, $100. You came, you saw us, and we charged you $100 for the care that we delivered. But you have insurance, and your insurance is with Cigna, let's just say, or Blue Cross, or whomever. Let's just pretend it's like 80% of charges. So that means I charged you, not me specifically, don't come after me, but the organization charged you $100. Your insurance company paid $80. And I'm just leaving the copays and deductibles out at this point. Did we get $100? No, we didn't get $100. We got $80, right? 80. Yeah, 80. Sometimes it feels like that. Some insurance companies, it's like that, but I'm picking on commercial right now. So if we look at that as being that 80-20, so we lost $20. And what that's called is a contractual allowance. That's because we have a contract with that commercial insurance company to send patients to us to say, we're in network. You ever heard that? They're in network. Well, that's because I signed a contract saying, I'd like to be in network because I want you to tell your patients or their covered lives that we will take care of them and we accept that insurance. So if you write that contractual allowance is also called a write-off. And that means we're not collecting it. We write that off. It's the cost of doing business and we think the benefit of being contracted with the insurance company outweighs that loss. Okay. So this is dated information, but when I was at the hospital, Medicare and Medicaid, it was about, you collected 44 cents on a dollar and 34 cents on a dollar. And this is old news. So it's not up to date, but those are your payers that don't pay. They pay the least in a hospital program, and the FQHC, they pay the best. So those are actually our best payments. For commercial, it's actually our worst payments. So if you think about what I just said on the $80 that we received, let's try going to the grocery store and they're ringing it up, right? Get your card. Used to be maybe like $50. Now it's like 150. You go there, you get rung up, and you say, "Yeah, I'm not feeling like 150. I think it's $100 today." All right. Do they ever say, "All right, that sounds great. Have a good day"? No, they don't. Come back and reschedule your next shopping trip with us. No. So it's an interesting piece when you look at the cost of healthcare and where the money then goes. So when you see these bills, and if you've ever gone to a specialist or a subspecialist, and that's again the primary care, importance of primary care, because we're trying to keep you out of the specialists and subspecialists because that's where it's really, really expensive. If you look at, I had surgery not long ago and it was about $36,000 for surgery, and I'm still paying that off at Dartmouth Hitchcock. But at the same time, they didn't collect all that $34,000. There was a huge piece of it they didn't as part of the contractual allowance. So that's oh yeah, you moved to how we get paid. That was kind of a nice migration. And so that's how we do get paid. Now for private pay. So if you don't have any insurance, this is what drives me crazy. You don't have any insurance, you come in and you see us, we charge you $100. How much are you paying? $100. You're not getting the $20 write-off because we're not contracted with you, right? So how's that fair? because we're one person. So now we have the sliding fee discount that we talk about if you can't afford it. But if you can't afford it, you're paying $100. And I'm going to send you a letter saying you owe me $100. So it's that this is where it gets complicated as we look into that piece. Now, the other ways that we get, does anybody have any questions on that? Because that's some complicated. Yep.
Who establishes that allowed amount? Is that purely the insurance company?
Industry. Yeah. So it's really kind of dictated on the industry side of it. Commercial is very similar. What commercial will do, and there's not a lot of commercial in the state of Vermont anymore. Most of those insurance companies have left the state of Vermont. But Blue Cross Blue Shield Vermont, we hear a lot of. That's probably the biggest one, right? And that they've been in the headlines. They had a big premium update or increase. And they're also on the verge of difficult financial pieces that they're trying to navigate, it sounds like. So it's really those industry trends. And we will look at them as how many covered lives do you have? And is it make sense for us to be contracted with that insurance company? Typically, yes. I contract with basically any insurance company if the terms are right, that will come to me. Like, yeah, we want to cover that person. That makes sense.
So there's not a negotiation.
There is, you feel like there is, but there's really not. This is where you negotiate. It's a great question. Where you negotiate is where the billing piece happens, not necessarily the rate. So you loved what I said about the $20 thing, right? You're going to really love this. So when I was the director of patient financial services, we have to get a bill to the insurance company in 60 days after the visit. Let's say it's either 30, 60, or 90 days. Those are typical. And I don't want to get too complicated on that. So if you don't, you forfeit the right to bill the insurance company. So 60 days, 30 days sounds like, okay, that's kind of, I mean, how hard can it be? Just send a claim into the insurance company and just get paid. That seems pretty basic. It's like invoicing somebody, they should pay it. Well, it's more complicated than you think. So we will send in, let's say, a claim to an insurance company, and the insurance company might not get it. I don't know how that happens, but that happens. We send them in electronically. We used to also send them in on paper, and we would send in a pack of 50 and they'd get 25. And I'm like, how does that happen? Right? There's also a form. There's two forms. One's called a UBO form, which is a hospital form, and one's called a HICFA. I don't even know what that stands for anymore. I've forgotten, but that's a 1500. And so those are the names of those forms. If you have any text that touches a line in the form, nope, kicked out. When I follow up with the insurance company like I used to, say I'm checking on John Smith's, service, they'll say, oh yeah, that got returned. You have to resubmit. Why? Well, because the letter touched the line. Okay. And so if there's any kind of error anywhere, I mean, what's an insurance company's role, main goal? Not to pay.
Not to pay.
Right. And so
the service you pay for.
correct. So it is a fight to get all those pieces in. And we used to do follow up. We'd submit claims in the morning, and the rest of the day was following up with insurance companies. And sometimes you can only ask about 2 claims at once. You have to then hang up, call back, get them again, ask 2 claims, hang up, call back. You can't just go through a whole list. So it makes it really tough to get paid for those. So let's get back to the 30, 60, 90 days. So that was a great question. Thank you. And so if you get back to the 30, 60, 90 day piece, if you end up getting seen today and you leave, everything's great, you got what you needed. You're gonna do an awesome review for us, survey that comes in the mail, thank you. And you have the clinician now that has to close that chart. Well, the clinician has to then document exactly what happened in the visit. And our visits typically are 20 minutes, 30 minutes, 40 minutes, sometimes an hour, depending on what type of visit it is. Do you see your clinician for 20 minutes, 30 minutes, 40 minutes, or an hour? Probably not, right? So you're coming in, waiting in the waiting room, filling out forms and clipboards sometimes. The nurse comes out, the nurse gets you, sets you up in the room, talks to you a bit, takes some social history. You wait a little bit longer, clinician comes in, sits down, probably has a computer, is trying to make eye contact, but also have to document what we're doing, because we don't want to miss that, because that's going to get the claim to the insurance company, plus it's important for your overall health care, right? So we want to do that. And then, okay, let me run out, we're going to get this, you change your clothes, You might see your clinician for a 30-minute appointment for 10 to 15 minutes at the most. Because you saw the nurse, you saw that whole process that happens, the documentation that happens. And then after you leave, after you check out, we have to still finalize that bill. So that documentation then equates to a code. And that code for us, I'm just pick on primary care, 99212 to a 99214 or 215. 215 means the longest visit or the most complicated visit. 212 is the easiest visit, let's say. So that's just kind of how that piece works. And it can be on complexity or time. Those are that's how we build things. So that still has to go through coding. So somebody has to look at that and audit that and make sure it's appropriate. Make sure all of the pieces that were documented in there, the time fits, and that the code that's being used is appropriate for what we're sending in the claim for. So that takes some time because they closed it, and then coding we see 100,000 visits a year. So they have to go through these and look at them and make sure they're appropriate. Because if you don't do it appropriately, it is fraud. If it's fraud, we get shut down. So that's why it has to be right. If we say, oh, this person's a nice person and they're really struggling, and it's really a 99214, let's say, but we give them a 99212, fraud. I don't see that one enforced as much, but that's fraud. I see the other way around, enforced much more. And so that piece is such a complicated piece. So now it's gone through the coding piece of it. We have these scrubbers that look at it, and then it goes to the insurance company. And if the insurance company gets it, great. That's going to take about 10 days probably from that. If they don't get it, we're then scrambling to resubmit it. We don't know they don't get it until we find out that we follow up or we haven't gotten paid. So you look at all the invoices you sent out, and if it's what we call aging claims in your AR, if that hasn't gotten paid, we know to call and find out where's it gone. Oh, it hasn't got there. We're at 20 days now. So if it's a 30-day, it's a scramble to get that there. So you can see that that's just the ugly side of it. And I said the other day, one time somebody asked me at the hospital, can you imagine if you only had to worry about yourself? And it was like the weirdest thing anybody had ever asked me. And I was like, wow, yeah, that's amazing. Because what we do is we worry about everybody, right? And so we're trying to make that difference. Well, what if we just saw patients and took care of patients? Didn't have to do this other stuff. So we have physicians that finish up those charts right after the visit, right? Wrong. We have physicians and PAs and nurse practitioners who go home at the end of the day and they eat with their family, and then they get on the charts at 9 o'clock. And I can sign in at midnight or 1 a.m. and they're still charting. And that is not a way to live life. So when you start to see primary care and the difficulty about recruiting people aren't going into this medicine anymore. Plus, if you look at how a clinician in primary care gets paid, it's a quarter of what somebody in specialty might get paid. So if you come out of medical school with a huge amount of debt and you want to pay off that debt, you might start thinking, I think I'll be a surgeon. I think I'll be an orthopedic doc. I don't think primary care is maybe for me. But what we find out is the people that are in primary care are here for the right reasons. And they want to take care of you and they want to keep you out of those specialties. And it's more of and I think this has been abused by healthcare as a whole. It's more of a crusade mentality for those folks in primary care to do the right thing. Any questions on payment for patient payments? Yeah.
Can you give us an idea this is how that those docs and you have to spend so much time on this stuff, which is irrelevant for providing what the patient needs. That's what it all boils down to. The state's talking about global budgeting and so on and so forth.
Yeah.
We'll see.
Right.
How does the payer mix boil down? At the end of the year, what Medicaid, Medicare, private.
Yeah. So our biggest, Ted, I can't give you the actual percentages, but our biggest is Medicare and Medicaid, followed by commercial, and then private pay is the smallest. And I'd say I'd have to get you the accurate numbers, but I would say a third probably is about Medicare and Medicaid. So to give you that piece of the breakdown. Those are, again, our best payers. Government payers typically pay on time. The games that I mentioned with commercial payers doesn't necessarily happen with Medicare and Medicaid, but it does happen with the commercial payers.
How does that compare with the status or payer mix?
Yeah, so we have an older and a sicker population and a more poverty-stricken population in the state of Vermont. Not extremely, but we are that area that's more underserved and we're affected by that. Yep. Yep.
If you're talking about reimbursements from the Medicaid, Medicare, and all the insurance force and stuff, who sets those amounts? If they're not, they never seem like they're enough to cover what's going on, so. Who
Yeah.
sets those amounts? Where does that all come from?
Yeah, good question. There's something that if you ever want to go down the rabbit hole on how that's set, Google fee schedules. So if you Google the Medicare fee schedule, you'll see what the allowed amount is for a test. And so I have to do everything I can to meet that allowed amount. So that would be CMS, that's the government. And then you have other payers, Medicaid, that will usually operate on the Medicare fee schedule, but it might be like 2 years ago and they haven't caught up to the newest one. Commercial payers are the same. So they typically operate on some sort of fee schedule set by the United States government. So that's that, and that hasn't matched, that fee schedule hasn't matched inflation. So anybody want to take a guess? I've gotten reimbursement adjustments like 3%, 4% annually from from Medicare and Medicaid. But not commercial. That's been relatively flat. But we get that 330 grant that I mentioned, the $2.7-ish million. Guess when the last time that was increased based on inflation and whatnot? Anybody have any guesses?
1989.
It feels like that. It feels like that.
That's the last time the gas tax went up.
Yeah. That gives me a good benchmark of kind of how it sold this entire presentation, 1989. It was 10 years ago. So 10 years ago, we got that adjustment. So we as a federally qualified health center, not for profit, 501c are pretty good at doing a lot with a little, but now we're doing a lot with nothing, actually less than nothing. And so how can I give the 205 employees an increase if I'm not getting that money? Well, I can't. But guess who pays better than an FQHC? A hospital or anyone. And so what happens is if you can't afford your groceries or your gas and you're looking at ways to improve your overall lifestyle just to stay flat, you're going to leave and you're going to take a job somewhere else. And we see that turnover happen. We also see bigger organizations, bigger hospitals that don't hire new graduate providers. And so those folks are out there trying to find a job and they come here, they stay until they get 2 years. And then they go to a bigger organization that says, yeah, you got 2 years experience, we'll hire you. And so we become a training ground and that becomes a difficult piece for recruitment, retention. If you've been with us for a significant amount of time, if you've had the same provider through your life, you're a unicorn because we've had so much turnover as an organization and as an industry across the state of Vermont. And as we see people taxed higher and higher and move out of the state of Vermont, we're seeing less people come in, we're seeing less population growth, and that's going to be harder and harder as time goes on. We can go to the next one because I'm going to just mention a little bit about another way we get paid. So this next slide will actually, I believe it's the next slide, break it down a little bit. So right now, every time we see a patient visit, so anytime somebody comes in, on average, it costs $312.74 to see a patient. And so 55% is seeing patients. 55% of our income is seeing folks that come in. We also take part in other grants and other revenues that come into our organization to supplement those things. So there's a big one, 340B. Has anybody heard of 340B? The 340B is a way that we're able to purchase pharmaceuticals at a discounted rate. We are then able to work with community partners, and you're able to go pick up your pharmaceuticals at the community partners, and they get a pharmacy. The way they get paid is a fill fee. And so if they're a community partner with an underserved organization like us, they're able to get a higher fill fee than if they weren't. And so there's a natural desire to work together. And so that difference of the discounted pharmaceuticals comes back to us, and we're able to put that into the organization to do enabling services, like getting the van out there or hiring or subsidizing any of the losses that I spoke about earlier. So that helps. It doesn't solve. Guess who hates 340B more than anything in the world? Big pharma. They want to shut that down because they're not making enough money. And they'd like to make sure that they hold on to every dime that, yeah. That was sarcasm. They're making gobs of money, right? In fact, they're putting my clinicians through hell every day when they try to prescribe something to you or order an X-ray or order an MRI and they say, we're not approving that. You can order an MRI for your patient, but we're not going to pay for that because we don't think they need it. And then Ted or Bruce might say, well, how long have you been practicing medicine? And so they have to go through an act of Congress, it seems like, not really, but they have to go through an act to then explain to the insurance company why they might need that MRI. The insurance company will say, well, they need a chest X-ray. Let's start there. And sometimes people will go get a chest X-ray and guess what they got to get right after that because it didn't show anything, an MRI.
I've always wondered who makes that decision with the insurance company. Is it simply a computer program that's receiving that referral and the computer says, nope, that doesn't fit the model?
Yes,
Yeah.
yes. And so and then you can go to peer. And then you're talking with a doctor that works at the insurance company. And you know what that doctor said? I hate seeing patients now. I'm going to work for the insurance company because man, it's too stressful on the side of seeing patients. And so you get into this peer-to-peer piece. Kind of beating up the insurance companies today, but I'm fine with that. Big pharma, I'm fine with beating them up too. So that's the 340B side. But 34% of our revenue comes from not seeing patients. That's weird. So that's going to be your 340B. That's going to be grants that we do, annual campaigns that we have, that support from our patients. We have municipalities that support us as well. And so that's a big piece. If this went away, if 340B went away, we'd go away. That's how leveraged we are. And so I can look at our income statement and I can start to think about, I don't run a health center. I run a pharmaceutical company now because we're doing the 340B side of it. Or I run an annual campaign company because we're not cutting at 55% of patient service revenue and it continues to go down. Now, the other thing I want to talk about is the revenue piece of it. Is the ugly piece of healthcare that drives me absolutely crazy. I talked about the time that you have with your clinician in the room, right? So in order to break even as an organization, have to have each one of our providers on average see 16 patients a day. So that's not healthy patients probably, right, that are coming. That's a lot of comorbidities. That's people that are at the end of life. You might hear other organizations measure it differently, 2.2 patients an hour, they'll say. And so now I have to go in and I see Miss Jones who comes in with this list of all the stuff. She's been waiting 3 months to be seen and she's got a big list. And that clinician said, I got 15 minutes to get through this entire list. I don't know how I'm going to do it, right? Patients are like, why? I've been waiting. And that just sets us up for a difficult conversation. And you walk away with that clinician doesn't care about me as much as I wish they did, right? And so I would tell you that our clinicians care about patients more than anybody else. And they will take the time to go through things, but they're not able to go through everything at once, sometimes. And this is a problem for sure, especially when you're a new graduate coming in and you're still learning and you're getting mentored and you're getting case reviews and things and going through stuff. So I don't have people seeing 16 patients a day. That's part of the problem that we have for our financials right now. And so if I push real hard and I say, you have to see 16 a day, it's just the way it goes, they leave because they're working until 1 a.m. And now you're asking me to work until 2 a.m. because I'm going to be closing these charts and doing this work. So it's a very fragile system that you have to really balance. And if somebody goes away, I'll get you a second, Ted. If somebody goes away, I call a recruiting agency to find somebody else because I can put an ad out that I need a family physician or something, let's say. And there's not just people walking down the road going, I'm a doctor, I need a job, right? Well, the recruiting agency will charge me $25,000 to find somebody. That's the reality of it. And so it's so important to hold on to our medical staff that are here today because we want them to stay in this community and grow. Ted.
You know, it's fascinating. We had with associates during the hospital in 2006, I think it was. We would routinely see 25, even 30 patients per day and spend more time with each one.
Right.
Because we didn't have to deal with I'll give it to insurance companies. Management. Outside the house.
That's right. That's right. That's right. I'm glad you said that, because I kind of didn't even mention, or I kind of glazed over that piece of it. So the electronic health record that I mentioned earlier, that was sold to the medical industry many years ago now. And it was going to simplify Ruth and Ted's job, make it wicked easy, because now you can just type everything in there. And you just click this box and that box. Well, that slowly turned into a lot of boxes that you have to check. And that starts to help build that code that I talked about earlier, right? And now you're not making eye contact with the patient, so you're not getting those cues that a patient might give you if, how you feeling? And if the patient's like, fine. Okay, fine. Okay, let's go on, right? So, it's that piece that you've taken out. The nice part is we're seeing AI come into the picture right now in a helpful way, I think, where we can do what they call environment AI. So we can have a phone recording the dialogue of what happens and go into text and populate the medical record. Anybody used AI? It's perfect every time, right? So you got to read the note. You can't just say, oh, we're done. You got to read and you got to look over that and you got to correct it. You got to say, oh, I didn't get this, I did get that. But what it does is I'm trying to get those medical staff members in bed earlier so they can feel like they have a life outside of their career, right? And what we're seeing with a lot of new folks that we do recruit into the organization is they might say, a typical physician's week full-time looks like working, and this is physician, PA, or NP, right? I'll just say providers. If a provider's working full-time, it's 4 days a week seeing patients, 1 day closing charts, admin, meeting us, and going over different things. That's how it works. But I'm seeing a lot of newer folks come in saying, I just bought this Sprinter van and I want to drive across the country. So I'm thinking maybe I'll work like 2 months and take 2 months off, or I only want to work 2 days. And then, so we're seeing a lot of people come into the organization where now one full-time equivalent, or FTE, I'll say, now I need 2 people to fill that. And the cost for 2 people is always more than 1. And so that's been an increase of cost as well. Any questions on?
Josh, do you have a census or how many no-shows you get on a daily basis? Like you mentioned, a provider has to see 16 patients
Yeah.
a day.
Yeah.
How do no-shows fit into that?
That's a good one. Good question. We're still trying to learn that and figure that out to the best of our abilities, but it's about a 13% no-show rate on average across our organization. And so what do? We book for 17 to try to help with that. We double book. Have a conversation with a medical staff provider and say, we're going to double book you at 1 p.m. and see how that goes. Nope, they're both going to show up. I'm not going to have time to chart. I'm not going to get this done. I have to call the insurance, all this stuff that happens, right? And we have hired additional people into the organization to help call insurance companies. We have people that are communicating directly with the insurance company. So there's been more expense that we've come in to try to wrestle the gorilla while we're trying to see the patient. Those are your care coordinators, those are your health team folks, those are your RNs, your triage folks in the offices. So that's about our no-show rate. So the double booking thing doesn't work well, for sure. But what we're trying to get is that 17 so we can get to 16. And it's a tougher sell for sure for folks in the system. Yep.
Can you talk a little bit about additional revenue from the ACO or other value-based programs that receive?
Okay, that's a good question. So accountable care organizations, the ACOs. So has anybody ever heard of One Care Vermont? Okay, so that's our biggest ACO that we've had. I'll give you a little history. So the idea of an ACO is good. The idea of it is good. And the reality, maybe not so good, from what I've experienced. So, and I don't really want to pick on One Care, but One Care is the one I really know. And so the idea is we are going to take funds, and if you're able to look at what it cost you to provide healthcare last year, right? So say it costs, this is baloney, but let's say it costs $1 million to provide healthcare last year, right? It's about $27 million if you want to know the real number for us. So it's $1 million to take care of your patients last year. If you do it, $800,000 this year, you're going to get shared savings. And so if you trim your costs, you're going to get shared savings that come back into the organization. So That's gonna be based on outcomes, patient outcomes, quality scores. That's gonna be based on expense. And so that makes me hire more folks probably to say, hey, we really need to see you. We haven't seen you in a while. We want to make sure you're okay, not going to the hospital because that's going to be expensive. So if you come in and see primary care, that's going to reduce the overall expenses. It's spending within the health shortage or health service area, or HSA, they call it. And so we're kind of grouped in with the Windsor County site. It's not necessarily our service area, but we kind of have this set throughout the state. So at the same time, you might have heard of upside and downside risk for the ACOs. So it's a little bit like Vegas. So you're putting a lot of, I think we can do this, but at the same time, if it doesn't work, there's risk associated with it where you might actually get fined and you might have to pay into it. And so the risk has to stay with an organization that can tolerate the risk. And at this point, that's only been hospitals. We have not ever had a risk ACO model. And so as you're looking through and as you're forecasting what it might be, and you're going to get an income piece of it coming from, or shared savings coming from it that you think you can help pay off some of the debt and whatnot. If that works, great. It doesn't work very much. I don't get a lot of shared savings, to be honest. But there's a lot of reporting and a lot of overhead that a lot of staff have to send information off to the ACO. That's going to be quality. That's going to be benchmarks. That's different than all the reporting I do to the federal government. It's not the same. We do something called the uniform data set. We have to prove we did what we did to them. We have to prove what we did to the state, and so on and so forth. So there's a lot of what I'm going to say is administrative burden that gets in the way of providing the care that we need to, or that actually providing the access to the care that we need. So when we went through Chapter 11, we were not able to be with OneCare for Medicare anymore. And that's because of the risk. The hospital at the time said, we can't tolerate the risk because we can't pay in, so we're fragile. The FQHC couldn't afford the risk, so we can't take it. And so we didn't participate with Medicare and OneCare at that time. So we found another ACO, and this other ACO is called Lore Health. Has anybody ever got a Lore thing in the mail and you're like, what is this? So Lore Health's another ACO, and they do things a little bit differently. They focus on lifestyle medicine, which is I'm passionate about. It's really, let's see how long people stay with me on this one. Who wants to have less stress in their life, right? Who wants to get better sleep in their life, right? Who wants to eat healthier? I'm losing some of you. But we can start to make little changes and eat healthier, right? And who wants to exercise? And it can be all sorts of things. When I say those things, it doesn't mean you only eat healthy now. It doesn't mean you only always exercise, but it's making life changes. And those life changes, we've seen reverse chronic conditions. We've seen people pre-diabetic go away from being diabetic, pre-diabetic. We've seen hypertensive changes. So we've seen those pieces change. And we've reversed some chronic conditions with that. That takes a lot of time you have to spend with patients. And when you spend an hour with patients, is that 16 patients a day? Nope. So that keeping you healthy through lifestyle changes and not prescribing medications takes time. And we're not paid for the time that it takes to do that, which doesn't make any sense to me. So I'd rather not prescribe anything if we had to, if we could make some changes in life. So the next piece on the ACO side of it, I'll mention from Lore Health. There's this app that they have, and you can go on and you can be in share healthy recipes and talk about your exercise, and you can get AI, what they call their bot, to, if you say, I feel depressed today, it'll talk to you. Say, I feel great today, it'll talk to you. Say, give me a recipe. I mean, it'll really work really well with you. And so that's a nice way of free. You can actually have benefit from that. You can get paid to be doing this stuff by Lore Health. And we receive a small payment from that every month. $6,000-ish. So not a huge amount, but that's one way of reaching outside of the walls of a health center to try to take care of patients in a better way. So that's where I say not all ACOs are broken. There's some good ideas, but sometimes there's some things that get in the way of that. We can go, oh yeah, so just to highlight, we lose $27 in every patient we see, based on what I just shared with you today. Who wants to start a business that does that? And we have board meetings every month that we talk about, oh gosh, how are we going to do this? And there's a lot of creative thinking on how we make this work as a regulated environment and how we're able to make this work with that that underserved or the underpayment for all the care that we can deliver. We can go to the next, Jess. So community health, it's just something, this is actually our mobile unit. If you didn't see it down in the parking lot, that's our mobile unit. This was actually parked at Ludlow Health Center when the Ludlow Health Center flooded. That entire population couldn't go to the health center because obviously it's flooded. And so we were able to park the mobile unit out there and kind of use it as, it's not crisis response, but we were able to use it as an access point for people that, we had people walking in that were cleaning up debris and cut themselves, and we were able to, stitch up lacerations, and we were able to see people that had an appointment, but it got canceled or got moved, and we moved all those clinicians that were here to this building, and it was hard sometimes for transportation. And that's something that the state, if you look at Act 167 and you look at other things as far as when they talk about, well, this hospital should work with this hospital or this FQHC should work with this FQHC, and we closed Rockingham Health Center because we couldn't afford to operate that building anymore. We also took Ludlow Dental and we collapsed that into Chester Dental. But if you don't have a car, that's a big problem. And if you're using the mover, that sometimes can cost some money. We give gas cards away. Community health team is a huge amount of that. There's an algorithm, so we're not just handing out gas cards, but there's an algorithm to make sure that you need it. We help people set up rides. There's Medicaid that pays for rides with the mover, but there's not enough public transportation as a whole. And so if you want to be seen by your clinician and you got your appointment and then your ride doesn't work out, you no-show, and you get a $50 bill for that, how's that feel? Right? So we can't make all these changes in the state of Vermont without having that infrastructure already built. So the community health team, I would say, does a huge amount of outreach. The 802-886-8998 is the direct number to our community health team if somebody's trying to establish care. The other piece is when we did a lot of primary care, correct me if I'm wrong, Ted, but or Ruth, because this is a little bit of an assumption on my part. For the changes we've seen in the education system as well as in primary care, is we used to be really responsible for your health in primary care. In the education system, we were really responsible for your education. That's why they call it the health center. That's why it's called a school. And so what we've seen is the collapse of the social network around these organizations. And so now we're responsible for your firewood, your heating oil, your gas, your social economic dynamics. And we have branched out to try to hold that line. And there's something that we're called as a federally qualified health center, and that's the safety net. The safety net is supposed to stop anybody from falling through the cracks. And at losing $27 a visit, how is the safety net supposed to stay together? So that's one piece I see within the school districts, where you have an expensive school district, you have an expensive healthcare system, but we really have to drill down to what has happened over the last 20 years, those organizations, and what they're now responsible for, as to what they were not responsible for years ago. So I also would say that there's a lot of outreach, the in-between visits that we do too for nurses that call and follow up on people. And I think it's really important that if you do get a call from one of our staff members following up, call us back if you could. Confirming appointments is really helpful for us too. We know you're coming. I've had people make an appointment in the morning for 10 a.m., confirm it, and they'll show. But whatever you can do to spread the word that it's really important for us to see our patients and have them come in when we're there. Go ahead. Nothing. No, I'm just kidding. This is the thing. So we struggled about this because when we come up with a town hall, and how we go through these processes, and I really want to turn over to some questions too, and what I would also say is, if you have a question, but you're not sure you want to ask it, somebody else already has the same question. So please ask it because everybody's wondering the same thing. And again, I don't know all the answers, but what can be done is we are advocating with state and federal regulators all the time. And so I'm speaking with senators, I'm speaking with congressmen, I'm speaking with state senators, I'm speaking with local representatives. And there's a strange thing that happened. So we had to consolidate Rockingham Health Center into Springfield Health Center, which is this building, and Charlestown Health Center over there. to really reduce our operating expenses, because I want that $27 to go away, that loss, for the whole system to survive. That was the hardest decision I've had to make since 2019, when we all went through Chapter 11 and we closed a childbirth unit. That was probably one of the hardest moments. And Bob, you know, you were in the boardroom. That was one of the hardest board meetings I've ever had to close a childbirth unit. I was born at Springfield Hospital, so two of my kids were. A third child couldn't be because it was closed. And so you have people traveling for that healthcare. And so I think really being able to advocate on the side of local healthcare is going to be important in the next 10 years. We're seeing the baby boomer population move through where there's going to be more health demand for that population. And we're seeing less people in the service industry to be able to take care of that population. And that's going to be a difficult piece. Too bad we didn't see this coming, huh? It's frustrating. We talked about this when I was in second grade. It looked like a boa constrictor eating a mouse. It's the bubble coming through, right? So it's not like we didn't know. So we're really trying to build relationships. And when I say those relationships, it's not just asking for money from the government, because that comes out of our pockets. But the whole system has to be changed, because what we're in right now ain't working. And I don't see a positive ending to it unless something changes. I was given a little bit of hope when I was at Scotney 2 days ago, and the AHS was there, and they said, we got to solve this together. They had the director of Medicaid was there. We got to work on changing the way we do things. There's this collective effort on changing the way we do things. But the problem that exists is if you zoom back, like we can talk all day long about collaborating and working together really well with other organizations. HCRS, partner of ours, healthcare rehabilitation services. We work really closely with Springfield Hospital. We work with other hospitals. We work with Valley Regional across the river. So when it comes down to it, and if you read Act 167 or saw the presentation where they say this hospital is only going to do this, and this hospital is only going to do that. Aside from the transportation problem that I already outlined, when you're sitting in a boardroom or you're sitting in a finance committee and you're looking at this saying, oh, I guess we'll stop doing this, and this is where we make our funds, but somebody else might be better than that. And for the good of the state of Vermont, we're going to give that up and let somebody else do it. And we're going to focus on something else. When you already have a 2 to 3% loss overall within the state, how in the world are you going to make that work when you're a private organization? Because a private organization has a fiduciary responsibility by an independent board to be solvent. And that's what we're all trying to be solvent right now. And so it's going to take a lot of folks to get in the room and have a conversation and to be vulnerable and think about how we can change the overall dynamic of the state of Vermont. Now, here's the other problem. That's just Vermont. So who wants to be part of that process? If you don't want to be, you're going to leave. And Vermont is not an island. We sometimes have heard that we're this small population and we can try different things, exciting. We've tried a lot. We've tried a lot in healthcare. It's not worked all that well. We've put out some big ideas. We always have big ideas. And sometimes those big ideas don't necessarily work and we become frustrated and people leave the state of Vermont. And that's hard. So you can't really lead with your chin when you're as small as us, because somebody can drive over to Lebanon and work at Dartmouth Hitchcock, or somebody can drive over and work at Albany in New York, depending on where they live. Heck, you can be telemedicine now and not even leave your house. You could be seeing patients in your pajamas, right? I don't see too many people doing that. At least pajamas from here up. So the industry is changing, and some patients want that type of care too. They want that on-demand care. It's very similar to you want your McDonald's cheeseburger right now. You want to go through the drive-thru and get it. And so if you try to get to your primary care and it's not working, you're going to do that telemedicine piece. You're going to have a conversation with that person that might call in an antibiotic, but what they might not know is your medical record or your history or any of that information. And because they don't know that, you've probably been on it. You may have been on antibiotics a lot. And now that's really causes some issues in your body and you're susceptible to other things. So that's the other piece that I and others are advocating on, is really transparency around medical records. While I don't always agree with the socialist approach. I think the medical record approach of having a universal record could be helpful for our system. Because when we talked about the care that was delivered here, but if we see a patient that then goes to Dartmouth-Hitchcock for a specialty visit, those notes come back to us. Your primary care provider for the 16 patients a day has to finish all those notes, but then they have to review labs that you got somewhere else, all the notes that you got from your specialist as well. And so that's your entire panel, say 1,500 people that are out getting care elsewhere, that then, if possible, come back to us and we're able to review, but it's not always possible. Sometimes you have to go look for it. Sometimes you have to get into another computer program and go look for it, which takes time. And that can delay care. And that can cause issues if we delay care. So, yes, Susan.
And this administration for the VA system is nationwide.
It is.
It goes to the VA, that's what can be done.
Yep.
But within the private, like Springfield hospitals and Arsenal are the same. And they
Right.
log into a different portal.
Correct.
Then those records have to be transferred.
Correct.
And then some hospital regions, it's even more complicated.
Right.
VA system, it is possible, it is nationwide.
Right. So I'm going to build on that, Susan. That's a great point. So I'll get to the VA in a minute, but if you go up to specialty and you go to Dartmouth-Hitchcock, has anybody gone to a larger tertiary health, like a hospital, like a Dartmouth or an Albany or anything like that? Okay. Have you ever gotten your notes from there? Okay. Have you ever read them?
Yeah.
Okay. They're extensive, right? Our notes are extensive. That takes time. But what does it say? It says follow up with Dartmouth-Hitchcock Radiology Department for your MRI. Follow up with Dartmouth-Hitchcock Primary Care for your next primary care visit, right?
It's a sales pitch.
It's a gravity. They want to gravitate to those places. And then you saw during COVID, what did Dartmouth-Hitchcock say to the population? Did anybody see that article that went out? If you have primary care in your local community, use it. Because we're full. We can't do it anymore. And where do you think Dartmouth-Hitchcock makes most of their money? Not in primary care, in the specialty services, right? So you used to be able to speak to folks that would go into a specialist if they had a chronic condition that needed that level of expertise, right? And that's specific focus on that one expertise. Whereas in primary care, it's a very broad range. It's your whole life we're looking at. And a lot of things can be managed by primary care. Not everything, but a lot of things can. And so we see folks using specialists for things your primary care can manage. And sometimes leapfrogging primary care and going right to specialists. And specialists, there's a lack of those too in this state. So when we try to refer somebody to a specialist and they can't get in for 3 or 4 months, that's a major problem, especially if it's a cardiac issue, right? What if it's a mental health issue? That could be as important as a cardiac issue. It really can be, because we see suicides, overdoses, those kind of things that take place. Go ahead.
Does Dartmouth-Hitchcock do better financially, say Springfield?
They're much bigger. They also had a loss last year. So no hospital in New England that I know of that's not for profit is doing great, or at the level that they need to. They had, I can't remember the exact loss. So here's a fun fact for anybody that wants to know about losses for not-for-profits. If you Google the name of the organization and 990, you will get into their tax filings. They're all public. You will see what people are paid, their top earners. You will see their grants, their charities, their revenues, and you'll see their bottom line on how they ended the year. And if it's if they're all audited, they have to be audited, but you'll see notes too sometimes of how they're doing. That's very helpful sometimes if you really want to see how they're doing, but I can tell you nobody's doing great, so it's a good question. Yeah.
And if you choose to not to answer this, that's fine. Green Mountain Care Board.
Yeah,
Net asset, net liability.
so
Feel free to say, I don't like it.
well, so as ending of my career, I just wanted to say, now, I think the intention of Green Mountain Care Board is good in the beginning, for regulating the way that the state has moved forward with healthcare expenses. I can tell you because I was the chief operating officer, chief practice operation at the Springfield Hospital too, so I had to testify at the state annually with the CEO and the CFO about how our spending is, our business plan looks like. The idea of the Green Mountain Care Board is to keep healthcare systems at an affordable rate, solvent, right? And also help the overall state plan. We've seen that continue to be funded. We've seen them also try to control the commercial rates as well. And what we see from a hospital perspective, and this is a little dated, because I'm not regulated by the Green Mountain Care Board. I'm regulated by the federal government for the most part. And the FQHCs, you know, I don't know if that'll always be the case, but at this point, I don't have to go to the Green Mountain Care Board. I can set my rates however I want. Now, that's a weird thing. So I can do, you know, the hospital sets rates, they have to say, well, we need a 5% rate increase or a 10% rate increase or whatever it might be. And the Green Mountain Care Board says, yeah, well, I reviewed everything. It looks like you're not going to need 10, you're going to need 8. And so you're going to have to find the extra money, eliminate a service, or do this. And that's kind of what you hear about and read. That's what a lot of CEOs in the hospital are talking about. The FQHC can up their rate and say that $100 that I said before, let's say we double our rates, which would be absolutely crazy. And now I'm charging $200. Guess who's paying the $200? Nobody. Insurance company's not, because we get paid on a fee schedule. We're still getting $80. Somebody walks in without any insurance, pay $200. So why in the world does it help to raise rates? Right? Doesn't. It inflates that contractual allowance. That's the primary care FQHC side of it. The hospital side of it, I can tell you budgeting in a healthcare system takes time, a lot of time. And you have to turn over every single rock to find out everything that you can cut, you can leverage to have more income. And you prepare this for not only the board, but you prepare this for Green Mountain Care Board. And then you have to go and you have to show it, articulate why you feel this way. And they have a level of being able to say, yes, this meets expectations, or no, it doesn't. And that takes time. That takes months. I know hospitals are starting that process right now. And
There's a significant expense involved.
just in getting that to them, right? And so that is a huge regulatory burden that you're distracted from running your business because you're having to build this thing. You're having to build the airplane while it's flying, as one analogy, or change the tire when the car's going down the road. So that can be difficult. I think the Green Mountain Care Board is going to have to really work with hospital stakeholders and find out the direction of where we're going to go as a state or the whole. I think there's pluses, I think there's minuses, but I think overall it's a huge regulatory burden for hospitals. Yep.
With the impending cuts to Medicaid.
Yeah.
How does the funding pot for FQHCs relate to that Medicaid that might we sweep through?
Great question. One of the other things that keeps me up at night. We don't have a good answer for that yet. There's a lot of uncertainties. So if you watch the news today and you might find out something's gotten cut, or there's a raid at one of the agencies and there's a big layoff and fraud, waste, abuse, and all these things are happening, or just overspending or grants that nobody's ever heard of. And this is getting a lot of attention. The one thing that really got my attention too are the cuts at AHS, or what they were going to call AMA, but HHS, Health and Human Services. That's HRSA. So HRSA is part of HHS. So I'm wondering, okay, the person I talk to every day, are they going to be there when I call them? Because they know who I am, they know my system. I'm going to have to introduce myself to somebody else, go through the whole thing with somebody else again. That's going to take time. I'm worried about that for sure. The Medicaid cuts, I don't know what those are going to look like yet. And if it's what is going to be our reimbursement from Medicaid as far as the encounter rate, which is what we get paid for every Medicaid patient that we receive, which is our best payer. If they reduce that, that $27 is going to get real big, real fast, that we're losing on every visit that we see. And we probably will not be able to do what we do for very long. So there's the reality of this, the reality of the organization, and this is not unheard of throughout the state, but about 2 months ago, we were operating at about 20 days cash on hand. Do people know what 20 days cash on hand means? Yeah. So yeah, it's not a lot of money. And so if you think about 20 days cash on hand, that doesn't mean that in 20 days it's done. That's not what that means. It means if all of the insurance companies and all of the revenue streams stopped, I can survive for 20 days. Yeah. And so your desire is to move that every day. So it's always 20 or more, and you really want to grow it. So you have what I call runway to survive. in case an insurance company has a big piracy situation or is hacked and all of a sudden you're not getting paid. Did everybody hear about that? That happened not too long ago. Well, all of our payments stopped. And we had to go through a huge process where we then had to hold claims. And so all of those claims are being held and we have to wait until they can submit them to then be paid on that. Well, you have to live off what's called reserves, cash on hand. And if you don't have it, you're not gonna make it. And so we're in better shape now. We're just over double that. We're about 53 days cash on hand. So we're continuing to grow that. Other FQHCs in the state of Vermont are at 0.1 days cash on hand. 0.1 days cash on hand. There's capital infrastructure and expenses that are not getting addressed in those situations. Those are going to be things like the filters in your HVAC system that have to be changed. Those are expensive. I cannot tell you how expensive the HVAC is. It's ridiculous. But unless you get a grant, you're not gonna be able to keep up with it. There you go. We didn't plan that at all. But if you don't keep up with that maintenance, people can have infections. We have to make sure that we're taking care of everything. There's nothing you can slide on. And we've done a really good job of taking care of all of these pieces, especially with respiratory illnesses that are going around, COVID included, making sure that we have ways to take care of the population that we serve. There's ultraviolet light now that kills a lot of this bacteria that we have in HVAC systems that we have in our system. Our mobile unit has that. Ludlow Health Center has that with the updates of the floods that we had.
Josh, one thing, just, to go down another rabbit hole too far, but, thank God for Bernie Sanders. And things that keep us up at night is our tires.
Yeah.
So what happens then, I guess on the positive side is in respect to the administration, WHCs generally have bipartisan support in Congress, a lot of rural areas. Have WHCs and they're necessary. There's a fragility involved. Domestic, or whatever Josh said, it's super fragility. Locally, statewide, nationally, for healthcare, particularly primary care.
Yeah, thank you, Bob. And we couldn't do it without Senator Sanders and his team. Senator Sanders was really instrumental in a lot of the funding that we received, including this building, as well as employee retention credit work that we had expedited through the IRS that we received after multiple years of waiting on. That's why our cash days went up. So really, those partnerships are so important. Absolutely curious on how that's going to go into the future with retirements and Doge and other things going through the federal side of the house. I can also say that because of the fragility of the FQHCs, I'm going to get a little bit out of the gloom and doom. I've been heavy on it today, but I think you all got the point. From the state side of it, they have put about $4.1 million, just under $5 million in the budget to stabilize FQHCs, state budget. That's probably going to come through Medicaid. But there's a real uncertainty from the state of Vermont on what Medicaid's going to do, right? And so nobody's going to act fast on that. At the same time, the Fed's kicked in, I think, about another $6 million. So it's about $10 million that's set aside for FQHCs. You saw the UBM headlines about the corporate executive bonuses. So we don't do that here, just so you're aware. And one of the things that I think they've reached a settlement and there's some funding going back out, and it said that funding is going to go to primary care. It's not, we don't know who that is. It says non-hospital primary care. That could be private practice. That could be FQHC. That could be not FQHC. We don't know, and we'll find out as the state tries to balance these pieces. But certainly that's Green Mountain Care Board trying to really level set the sites, whereas it's not necessarily a free market anymore. So I talked about us being a primary or us being a private organization. Did anything I say today sound like a private organization that you run? No, it's very regulated. It's a quasi-public private organization. So I want to give you time for comments and questions, and I guarantee if you're not the only one that's thinking about it, I recognize some of you from the other things that we've had. So I'm sure you have some questions too. So we got about a half hour left. If anybody needs a bathroom break, there is one right there.
Ellen has a question.
We were scheduled to go until 10, but
Okay.
we can say we have dropped until 10:30.
Yeah.
I was in a buffer, and so we can stay till 10:30. If you do have to leave, we understand. That's for anyone online. This is being recorded, so it'll be sent out. If you're on our email list, it'll also be on our website. So if you need to leave, that's totally fine. Please grab some food. We have one question online.
Oh, great. Okay. Yes.
Okay, what is exactly is the relationship between the hospital and North Star Life? Because you're talking about being FQHD, and I thought the hospital was.
Yeah.
I didn't, what is the difference?
Good question. So we are not part of Springfield Hospital. Springfield Hospital is an independent 501c3 critical access hospital. We're an independent federally qualified health center, FQHC. We work together closely, so we collaborate with patient care. We refer patients to the specialists up there. We then get patients down from the hospital, returned to our system. So we work closely with them, but we do not work together. We're not the same company.
Basically, we got split apart in bankruptcy. Perhaps, we got split apart after the bankruptcy.
Yeah, we used to be like this, FQHC hospital, and it was a drop down within the organizational table. And then we took the hospital out when the hospital was trying to find a dance partner through bankruptcy or a partner, a healthcare partner for ongoing sustainability. And we became independent. And there's some regulatory reasons of why that had to happen. Good question. Yes.
So I have a question and a comment.
Great.
I'll start with the question, and I'll make a comment, and then I'll let you answer the.
Okay.
So this is sort of building on the thing about what you think might happen with Medicaid, when you were talking about the grants that you rely on, the 330 and the 340 grants. I'm wondering if you're anticipating that with the federal cuts that you might lose that income as well. So that's my question.
Okay.
And my comment is that I couldn't agree with you more that the whole system has to be changed. And I'm actually part of an organization, there's 3 of us here that are part of an organization that is actually, you're working with, on the provider side, where people who are, some of our members are actually work in healthcare, but we're like, I'm a patient, I'm not a provider, but organizing ordinary people to try to preserve Medicaid and ultimately have a system that isn't as crazy as the one you described with the millions of different sets of paperwork, all that extra work that is not actual healthcare that providers have to do. So if people are interested in, as ordinary citizens, we'll be here, come and chat with us afterwards.
That's great. And I'd love to catch up with you too after this. Yeah, I'm worried about Medicaid disappearing in some way, shape or form or some portion of it. The hard part is it's out there. And so I have patients coming to me that think their benefits have been cut already and they think they can't come in and see us, and that's inaccurate. But we do feel there's definitely going to be some sort of change. And sharing what I had at the roundtable for discussion around Medicaid cuts, I don't know as though it's going to come the way that we think it's going to come. I don't know if it'll come on the reimbursement side. Last time the government needed some more money, they ended up doing this, what's called sequestration. I don't know if anybody's ever heard of that, but basically for some processes we have, like the dental process, we settle out at cost. So it costs this much, we get reimbursed this much, there's a shortage of this much, we settle out at the end of your cost, so we break even. That's only with dental, but sequestration takes 2% of that, so you're not at cost anymore, you're just less of that. It was 1%, it's either 1 or 2%, I think it was 1 and then it went to 2, but don't quote me on that one. And so I think that there could be a reimbursement shortage that way, and that would then collect additional funds back into the pot, if you will. But it may come from enabling services. And the state's going through a revolution on the state side right now with getting rid of the one care, so ACO is kind of changing. We're going to the ahead model, which I don't even understand enough to talk to you about yet. There's a gap, there's the gap year, so that doesn't start till 2027. And so how does the funding happen in between there? So there's just a huge amount of uncertainty.
It was actually a presentation to House and Senate Health Committee from someone from AHS about the most likely places that the feds are looking to cut. Reimbursement was one of them.
Yep.
The other one is just kicking people off of Medicaid, like getting rid of the Medicaid expansion. So if that's one of your sources of income to keep this center and the other centers going,
Yep.
and people get cut off,
Yeah,
then, they're gonna fall into one of those other categories of charity care or bad debt, the other things you talked about. And they're gonna be sicker
that's right.
for not getting primary care. So that, and then work requirements, which is a whole other
Yep.
boondoggle, they're all gonna affect the survival of this center and the other centers that you operate.
I could have said it better than that. Nailed it. Absolutely. Other questions that people might have?
So the question.
Yeah.
those as well.
You know, I think there's FQHCs, take care of a third of Vermonters right now, so that's just in Vermont. But in the country, there's FQHCs all across the country. This really came out of the civil rights movement in the sixties, if you want to learn more about it, but taking care of underserved populations. So I think they really have to look at that if they start to cut 330 grants, or if they cut any other funding, like the 340B pharmacy. And pharmacy has lobbyists that are at every day trying to get that gone. And that's really a lifeline for us right now. So if that even gets fragmented, that's going to be an issue. We're actually starting a pharmacy here. We're starting a pharmacy in Mountain Valley, and we're starting a pharmacy in Charlestown. And that's going to be our own in-house pharmacy. So you can see us and go down and get a prescription filled if you need to. And that's probably going to happen this fall. And that's a one-stop shop, really be able to do that. And that's going to really help us as well financially, but also help patients not to drive around. You come here once, get a mover van, you come here. So I think the 330, why I'm pausing with some of this is the 330 grant is usually approved. It's a 3-year block, and it's usually approved annually. We see those, what they call notice of award, comes from the federal government saying you've been awarded this grant, and this is going to go for the year, and this is the amount. What I'm seeing is that I'm seeing it approved in increments now, not a year. So that's causing a little bit of heartburn, right? And so the other thing that you don't necessarily know me, but I share all of this with my employees. And I'm trying to be as transparent as possible because I think as a CEO, you have to let people know where the heck you are. Because I've been on the other side of that. And so to be able to be transparent, not scare people away is a difficult balance. As you see this thing coming that might not be real, but it's something you need to worry about, is really the frustration and the fear. Hopefully that answers the question. Okay. Yeah.
Well, last year I was very sick. I was hospitalized about things. Then towards the end of November, I ran into insurance problems, and it took me 4 months before it was solved. And you know, we're so used to this system. We're so used to this system that we take it for granted. This is the way it's going to be.
Yeah.
And it doesn't have to be this way.
Right.
You know, you mentioned, you know, pharmaceutical companies. You know, we're the only country in the world where the health government doesn't negotiate. Not the only country, but the Western industrialized world, where we don't negotiate with the drug companies to get a better price. I saw the other day an interesting figure out of all the Western industrialized countries. Only the United States is where you go bankrupt because of healthcare costs. Last year, 325,000 people went bankrupt in this country because of medical costs. Doesn't have to be this way, and a whole lot of this has to do with pharmaceutical companies, a lot of private hospitals. I've heard some horror stories from some people that work in HCA. But it doesn't have to be this way. But we're so, you know, talk about getting the government more involved. Oh, that's socialism. But maybe, but you know.
So is Social Security.
Yeah. Social Security.
Yeah.
So I'm really, I have to say, since because of all of what has happened, what I've experienced and what I've seen with other people, I am very, very radicalized right now with this. It's, we're getting screwed.
I heard some. It's over here.
We'll talk.
You're not alone in that thinking, and you're not wrong. And some of what I would say, if you look at the healthcare, Google in your spare time, healthcare expenses globally, look at the United States and look at other countries, and then look at mortality, infant mortality rates. Look at some of the outcomes. It isn't working.
It is, most of the problem with infant and maternal mortality rates in the United States, you find in the red states. And, you know, they're not really pro-life, they're pro-birth. Just as long as the baby comes out of the mother, that's all they care about.
No, Christian.
Josh, to build on, I thank you for doing this. I think it's so important that, North Star is taking the lead to get this information out so people can understand. And I think you'll sense that frustration the more you do these.
Yeah.
And it's not with North Star, but it's with the system. So I think the more we can educate people on the fragility of the system, and the understanding is these are local people trying to do good things for our community. We need to make a change system-wide to improve the outcomes of the healthcare system. So thank you for doing these. I think they're fantastic.
Well, thank you, Christian. We certainly have, go ahead, Jess.
I was just gonna, to piggyback off of, what everyone's saying too, I mean, as a nonprofit, we are a little bit limited in what we are able to do as far as advocating and lobbying for system-wide change, but there is really good work being done in the state. I think Vermonters and folks in this region are really good at mobilizing when they're worried about something happening to their care or their education, and we're seeing a lot of that happening across the state. So connecting with people about what you can do and on banking and things like that, and calling your legislators, I think is kind of the best step now. And we are looking to kind of support that work as much as we can.
Great point. And we have what's called a community health needs assessment that's going to be coming up. We're partnering with Springfield Hospital to do that like we normally do. We're going to have focus groups so people can be invited to talk to us and share their stories about that. That's going to be really important because we have to position our organization on what we want to focus on, which are those social determinants of health or those underserved populations that we need to move our organization to best serve. So that's something too that people can get involved in. Right. I'll be right to you.
I felt for a long time, both in my life as an educator and observing healthcare in America, that we have these behind the scenes issue with what I think is one of the most dangerous things in our group thinking, which is it goes without saying assumptions about truths. And I think it is well established broadly in the minds of Americans of all political stripe, of all socioeconomic groups, that we have the best healthcare. And I think the vast majority of people, it goes without saying that we have the best healthcare.
Right.
And at the same time, we have extraordinary providers, we have extraordinary organizations, but we have systemic issues. And I keep wondering about how do we get people at the grassroots level on board with, we need to change this system, which you believe is the best system in the world. So any change that's going to happen is therefore going to hurt this wonderful system. And even though my personal experience is, it took me 4 months to get an appointment with practitioner A, we have the best system in the world. And that's a heck of a dilemma.
It is.
I don't think.
No, we don't.
Yeah, no.
It's so broad.
Definitely not. The one thing the VA question, I didn't expand on, but I'll bounce back to that. So the VA is run differently than state or private organizations. Obviously, the government hospital takes care of our veterans. Some things that are nice, we didn't even get into licensing today about medical staff, where we have to apply for licenses for them to practice. And there's a big credentialing piece and enrollment and insurance. VA doesn't have to do a lot of that because they're federal. So you can have a state license in Vermont, you can go to Kansas and you can practice. That's the only kind of thing you can do that with the federal government. We all have to have specific licenses for the states that you practice in, and that includes telemedicine. So if we're taking care of a patient in Massachusetts, we gotta be licensed in Massachusetts to do that on the telemedicine side of it. So that's just that piece. The other piece that the VA does very well is they pay for it. And so it acts as a vacuum from clinicians from my area to then work with the federal government at the VA structure, which shortages us, unfortunately.
Yep, when I first was gonna be coming to this forum, I heard the word CEO, here together. It's just a mindset that I had from the news and everything that's happening in this country. I just want to thank you for coming forward. Because
You saying that. My question was going to be, did everybody learn something today? And my hope is yes. And I couldn't do it without the team. So we had several team members, Jessica, Lori, Bob's on our board, Christian Craig, Susan on our board. Helena in the back corner, who's the CHD, Robin Prevey, who does dietitian work, and nutrition work. It takes a whole community to take care of a community, and all of you know that. Is I can tell you, there's days that we leave here, and we're wondering if we're going to make it to just mentally to the next day, because it's such a frustrating environment to work in. And when we see patients come to the window and they're frustrated because they couldn't get in either, we want nothing more than for you to get in. And we want nothing more to give you what you want. And sometimes medically giving you what you want is not what you need. And so there's that dynamic too. But we really are trying to do what we can with very little resources.
I just want to make sure that on the slide that you say $27 a patient visit, the takeaway is not for patients not to come in. It's the whole thing.
Great point. Yeah. Yeah, so there's a couple ways to improve, great point, a couple ways to improve the loss of $27 per visit. There's two ways: change in reimbursement so you get paid more for the visits that you do. I covered that in great detail. The other way to do it is see more patients per day, have more volume come in, and that volume will then subsidize the overall overhead or expense, right? So when we were looking at this last year, we knew we had to make an adjustment to our constellation of health centers as North Star Health. First time I've used that, beta test. We knew we had to make a change in Rockingham. And the way that we had to make that change, we were enemy number one in that community because we were pulling out of that community. None of us wanted to do that. None of us wanted to pull out of that community. At the same time, we're trying to run an organization and a private organization that we want to be sustainable. So we have to make necessary difficult decisions, and hoping and praying that all the employees that we said we were keeping all our employees and we're moving them to different places. So I didn't want to hurt employees. That was very important to me. We hope that the patients come here still, right? So you have to balance that, because if they don't, there goes that volume that I had, and I still have a cost piece that I have to balance. So yeah, certainly coming and seeing us is very, very helpful. We need that to happen more and more. Yes.
Thanks. Is there any chance that mobile unit would make up for some of the loss? I mean, Rocky,
Yes.
those losses now like a healthcare desert.
Yes.
And
Yeah.
there is no place for them to go.
So people might not know this, but the mobile unit, Helena, was down there last week and seeing patients. Saw a couple community members. We are going to be putting that out more on social media. So the mobile unit will be down there. We have a pediatrician that would like to go down there, maybe quarterly, maybe more than that, to be seen. And I explained the whole issue that we face if we see 2 patients in the community, we gave up seeing 8 patients here or 10 patients here. But the fact that there's that transportation issue that exists in the state of Vermont, that outreach is going to be so important as we move through. So yes, there is a plan to continue to do that. We still have Rockingham or Bells Falls as part of our service area, even though we're not in that area anymore. And the van has been parked at Fall Mountain Pharmacy. And so that's where we have that. And we'll continue to put that out on social media when we're out. Good question.
Is from Nicholas Cushman, who is the EMS chief at Saxon's River Rescue. And he said, given the recent closures of several local primary and urgent care centers, as well as VNA's notice that it will no longer provide care to much of our area, has North Star considered reaching out to local first response EMS or ambulance service to develop a mobile integrated health program? These community-based providers already have the infrastructure and trust within the population to bridge care gaps, especially in high-risk or homebound individuals. The partnership could help address the growing healthcare access issues in our rural communities.
Great question. The answer is yes. We have been speaking with different folks around that. We've had preliminary conversations with rescue squads, both in Chester. I've had one conversation with Rescue Incorporated down in Brattleboro. They actually received a grant. They're working with Brattleboro Hospital to do some of this. People may have heard of the community nursing approach too. I think Chester has one, Londonderry has one. Springfield does not have one, but that's another way to get out into the community that could potentially be a lower cost, making sure people are healthy, and when they need to be seen, they have to be seen. So I'm open to that, so please communicate me and talk to me more about that. I think there's some great partnerships we could have with the mobile unit to be able to get out and take care of folks, because what we've done is we've gone to, senior living, and we can park the mobile unit there. And the way that the mobile unit works, so we can't just stand in the plaza and see people and get paid. It doesn't work that way. But if I have the mobile unit with me, it does, because that's a health center on wheels. And so that's designated health center space. So if you are seen there, that's like being seen right here. I can see you at your house. I can't, I'm not a clinician, but a clinician could see you at your house, and we can be reimbursed for that. So nursing homes, those are people's homes. Independent living, people's homes, we can do that. But at Shaw's, we can't do that. So there's a lot of like regulatory pieces around that. So if we were able to take the mobile unit with us, we could certainly expand services with Rescue. And there's the grant with Rescue Incorporated, just read about that. That's, I think, a good trial for folks. And I can't remember who the grant's with. I want to say it's a commercial payer, but I don't know if that's accurate. So there's some good thoughts about that outreach and getting back to the black bag, door-to-door black bag physician kind of thing that we remember when we were kids. So will we ever get back there? I mean, there are folks that do that, and that's their business model. They're entrepreneurs, private physicians, you pay cash, and that's it, and they're on call for you. We are not that organization. We can't afford to be that organization, and our mission and vision is really to take care of the underserved population. Any other questions that the group has? I kept you a half hour longer than I even knew, which is great. And you stayed, maybe because you're sitting in the back. Yep.
How do people in middle schools find out how to get a ride?
So the best thing to do is call the number that we had up there, the 886-8998, which is our community health team, and they'll help navigate with the mover. The mover's been helpful for that, and there's also other ride shares that we've worked on. Actually, I know the action, what's the team? Project Action. There was an email that went out to all these members yesterday and said, we have a person that needs transportation to this location. And we jumped on that, responded right away, set it up, and we will be there. So that's the coolest thing, that there is a way to do it. And that information is also on our website. And so if we need to get that information out more, let us know how to best to do that. You had a lot of choices. This is the airline thing. You had a lot of choices this morning. And you chose to spend your time with me. And I really appreciate it. The other thing is, this isn't the end. So if there's anything that you want to do to continue conversations, please reach out to me. I'm available. I'll make time available to talk about how we can really work towards this. The takeaway message I would say for you, advocate on behalf of your local healthcare organizations. We're not going to be here if you don't. And that's going to cause a huge change in our population and our overall life expectancy, which is getting reduced right now. So thank you all so much for coming. Really appreciate it.